Welcome to Module 5. In this module, we're going to discuss ongoing fluid requirements. So it's fluid requirements going into the next 24 and 48 hours post-injury, cardiac issues, ongoing airway management, as well as other things that may crop up like renal issues, nutrition, labs and other exams, as well as medications like anxiolytics, analgesics, and neuromuscular blockades. We're also going to be discussing miscellaneous items such as fast hugs, comorbidities, and the use of the multidisciplinary team. Now we're going to talk about ongoing fluid requirements for the burn patient. Now we're going to look at resuscitation fluid management. Now we're going to go beyond the first 24 hours. We've already talked to you about the first 24 hours and how to resuscitate patients, but now we're going to look a little further on, going past the first day. So we're going to continue to adjust fluid rates based on urinary output, keeping in mind that the ideal goal urinary output for patients is about 0.5 to 1 milliliter per kilogram per hour. It's generally going to end you up around 30 cc's. Keeping in mind you want to go back and look at your labs such as sodium, chloride, base excess, and keeping an eye on the albumin as well. So you got a couple groups of patients that are going to hit you with fluid management. You've got your patients that are going to respond to the initial resuscitation. These are your patients that are going to have ideal urinary output. They're going to have maintained great hemodynamic stability. They're going to have not had abdominal compartment syndrome. They're not going to have had any of the other sequelae that may come up in a burn patient. These are your patients that you're going to start titrating their fluids down, keeping an eye on their urine output, making sure that everything is just going smooth as silk. It's not always the case though. You will get a lot of patients who do not respond to their initial resuscitation. So with these patients, keeping in mind, once again, as you already know, that urinary output is going to be our most sensitive indicator of how we're resuscitating, what our fluid status is. So with that being said, keeping in mind that 0.5 to 1 ml per kilogram per hour is ideal, you would go up on your fluids, not bolusing the patients. Fluid bolus is contraindicated in larger burn injuries like this. And generally we keep our fluid options to lactated ringer or hypertonic lactated ringer in burns greater than 30%. When coming down though off of the resuscitation phase, as far as your maintenance fluid, D5.5 is an option, as well as normal saline. And the colloids probably should have started to come off already after the first 24 hours. So diuresis of the resuscitation fluids. Diuretics are rarely used during the resuscitation period. We do not use diuretics to produce urinary output. We use fluids to produce urinary output. It's not uncommon to see a weight gain of up to 20% of the pre-burn weight, which is very common in extensive burn injuries. Spontaneous diuresis is usually going to begin around 1 to 2 days after the post-burn phase and when after colloid replacement's been initiated. Keeping in mind that this may be delayed if your patient has been unresponsive to the initial fluid resuscitation, as we discussed a slide or two ago. Rapid weight loss of the weight gain is not desirable. Generally, you want to lose only about 10% of the body weight. Diuresis of resuscitation fluids. Rapid diuresis can end you up with a few things. You can obviously run into hypotension. You can run into poor perfusion of the burn wound, and with that, you can accelerate the conversion of your wounds or take a second-degree wound and turn it into a third-degree burn because of the lack of fluids. So rapid diuresis may be prevented by just going up and increasing your fluids. So now we're going to look at fluid management after the first 48 hours. So you've gotten a couple days into this by now, and you're starting to get used to your patients being with you. If you've started colloids like an albumin infusion or an FFP drip, you want to start tapering those off by this time. Continuing on though with your maintenance fluids, making sure that you're keeping a good urinary output. Evaporative losses from the wounds will start to increase though. We've got a formula here that you can see on your screen that'll calculate your insensible water loss for you. As I said before, as you guys already know, titrate your fluids based on urine output, keeping an eye on your labs such as serum sodium, and also keeping in the back of your mind the insensible losses. And a very good indicator of insensible fluid loss is through body weight. So it is ideal to have the patients weighed every morning before you round, just so you can see if there's any big shifts going on with body weight. If you've started to tube feed your patients or they are drinking or eating on their own, If people are downing tons of water, or you've got tube feeds running, make sure that you adjust your fluids to account for the enteral intake that you have, that you're administering these people. Complications of excess fluid administration. This is one of the big problems we have in burn care, but it's something that it's walking a tightrope and a fine line. So one thing you can end up with is generalized tissue edema, which is could lead to decreased function of all the organs and contribute to multi-system failure. So in the pulmonary system, true pulmonary edema is uncommon, but later on you can run into ARDS, which is where lung tissue edema, and you've gotten a hyperproteinemia state going on that has contributed to your ARDS. In the cardiovascular system, very rarely will you see CHF due to resuscitation fluids, except in the patients of your elderly population and people that have pre-existing comorbidities like CHF, coronary artery disease, past MIs. Another complication of over-resuscitating patients is abdominal compartment syndrome, and it is found more in patients that have suffered from circumferential abdominal and chest burns, burns to the torso. It's associated with excessive fluid resuscitation coupled, as I said, with the extensive circumferential burn. This is where utilization of bladder pressures, if you're starting to suspect that your patient is, you see their abdomen starting to distend, use of the bladder pressure at this phase may be something you may want to watch about every 6 to 8 hours just to see which direction you're heading in. Abdominal compartment syndrome starts to rear its ugly head. You'll start seeing that your patient will be hypotensive, and this is due to the decreased cardiac output that's been exhibited from the pressure. You're also going to see on your ventilator a decreased tidal volume and an increased peak inspiratory pressure. The decrease in lung compliance may lead to an increase in tidal CO2, and then your CO2 is going to start rising on your blood gases. Abdominal compartment syndrome, as you all know, if going untreated, can reduce, is definitely associated with an increased mortality rate. Moving on to extremity burns. Edema formation continues within the second 24 hours post-burn. This is where neurovascular checks are essential, monitoring pulses hourly, especially in circumferential burns. And if you can't palpate the pulse, definitely using the Doppler exam to keep an eye on that will be of assistance to you. Elevating the burn extremities. If pillows, if that's all you have, it's better than nothing. Ideally, a Murphy sling is the way to go to get their extremities, especially their arms, up above their head and above their heart, and keep that edema down. Loss of pulses may indicate hypotension. You may have a need for sclerotomies if you start losing your pulses, keeping in mind compartment syndrome, which could lead to vascular injury. Continue using your Murphy slings for upper extremity circumferential burns if indicated. As I mentioned before, hourly neurovascular checks need to be performed looking at the 5 P's of compartment syndrome, which are pain, paresthesia, pallor, pulselessness, and the failure to thermoregulate or poikilothermia. Now I'm going to look into some cardiac issues. With proper resuscitation, cardiac output generally normalizes 24 to 36 hours post-burn. As you can see on this graph here, it's a little bit of a busy graph, but it shows an ebb and flow state of the time for the post-burn along the bottom axis is in hours, and the fraction of predicted normal values is on the axis going up. After 36 hours, the metabolic rate starts to increase, and with that metabolic increase, that the cardiac output may reach 2 to 2.5 times the normal rate. Invasive monitoring, the things that you really want to look for are to continue invasive monitoring if indicated, especially when initial fluid resuscitation is you're starting to really give a lot of fluid. You're starting to get in out of that 4 mils per kg to TBSA up to 6 mils per kg per percent TBSA burned. In the elderly patients, people with pre-existing cardiopulmonary disease, people with extensive burns with an inhalation injury. You want to normalize your cardiovascular function. You want to correct the hypovolemia first. You want to keep your CVP greater than 10, and keeping in mind that high peak inspiratory pressures and keeping a PEEP up on your vent, especially PEEPs above 5, can raise the intrathoracic pressure and mask some of your hypovolemia a little bit. Low cardiac output is definitely common in large burns. Consider dopamine only if hypotension is refractory to volume loading. Dopamine is not the first line pressor to use. These patients are usually tachycardic to begin with, and they're usually pretty dry, so not the best thing to use. Try fluids above all before using any pressors. Arrhythmias, generally the arrhythmias that we see are a lot of AFib, some SVT, but generally people are in a normal sinus tachycardia rhythm, so which is normal for them in this burn state. Now we're going to go into some issues of airway management. Continuing the airway assessment is crucial in these patients. The need for intubation will have probably been recognized within the first 12 hours post-burn injury, but this is not always the case. If the patients are not already intubated, frequently reassessing the patency of the airways is crucial, especially in patients that have suffered from facial or neck burns, or patients that are receiving high volumes of fluid due to resuscitation, and you notice that the edema is starting to form. Just keeping a good ear on their lung sounds, breath sounds, as well as listening to their voice, having them talk to you, and that'll give you a good sense of where you are with their airway. If your patients have been intubated, you want to keep suctioning them frequently. You want to maintain patency of the airway, especially when an inhalation injury has been suspected or is present. Utilize the pulse oximetry and end-tidal CO2 monitors if they're available. Airway and facial edema in burns is generally going to peak within the first 72 hours or 3 days post-burn injury. Always protect the airway by constant assessment, relying on the assessment of your nurses, listening to the respiratory therapists. Elevate the head of the bed to reduce some of the edema that may form. Extubation is discouraged until all the edema has resolved. So don't be too hot to trot to extubate somebody if you've given them a lot of fluid or if you're suspecting that there may be an inhalation component involved here. Utilize your bronchoscopy to assess the airway when available. So talking a little more into looking at a bronchoscopy, if you suspect that anyone has had an inhalation injury or anything of the like, bronchoscopies are definitely indicated. So if the initial bronch was normal, but there's clinical suspicion of inhalation injury, repeat the bronch in 24 hours. Better just to go ahead and do it one more time just to make sure. Because under resuscitated patients, they're coming in, they're dry, they're a little behind the ball. On fluid resuscitation might not show the airway edema initially, so it can masquerade itself a little bit. So that's why daily bronchs can even be indicated in these people, just to get down there and really clean them out good enough and get some of that crud that has built up in their lungs. Modes of ventilation that we use, pressure controlled low volume ventilation. Inverse ratio if you need to. We do allow for some permissive hypercapnia in these guys. Generally we like to keep the PIPs below 40, as you know. Keeping the FiO2 less than 60 if possible, which can be a challenge in the inhalation injury, especially as you've piled fluids on top of that injury as well. You want an acceptable pH is usually greater than 7.2, and try to keep your sats above 90%. Pneumonia is a common finding, obviously in patients that have been intubated, but in patients that could have been exposed to smoke or other burning chemicals in a fire. Patients with inhalation injury are at higher risk for a bronchopneumonia, and the bronchopneumonia can increase mortality by 40% when it's coupled with an inhalation injury. Early pneumonias are often gram-positive organisms. Prophylactic antibiotics are not indicated. Generally, we do not start antibiotic therapy until positive gram stain and culture has come back. Steroids increase mortality and are contraindicated in inhalation injury patients. Some of the pneumonias, as you already know, just for review, you've got your nosocomial pneumonias, which are your hospital-acquired. Aspiration pneumonias, that's why it is important to get, when your patients first come in the door, if you're going to be intubating them, get an OG or an NG tube down there and decompress their stomach if you don't know what they've had to eat or drink. And then you've got your ventilator-associated pneumonias, which we find generally in patients that have been intubated for 3 days or greater. Some aerosolized treatments that may be used in the burn population. We use a lot of albuterol, which is administered by our respiratory therapists. Can be exceptionally beneficial in patients that may have suffered an inhalation injury or have inhaled some smoke or other chemicals from the fire that they've been in. Some renal issues that you may want to keep an eye out for, definitely, as we've now gone over multiple times, is the importance of watching for adequate urinary output, 0.5 to 1 cc per kilogram per hour. Keeping in mind, if you've got a patient with a very deep burn, you may run into myoglobinuria, which is the red pigment being released into the urine. If myoglobinuria is suspected, turn up the fluids and get the fluids up there to try to clear the urine. You're going to see this generally in more of patients that have suffered an electrical burn, patients that have extensive, very deep burns have burned down to the muscle. So we're looking at generally 3rd and 4th degree burns that are going to produce myoglobinuria. If increased fluids isn't working, you can look at adding some sodium bicarb to the IV fluids to alkalinize the urine as well. Keeping in mind watching your BUN and creatinine, and watching that the creatinine, if it starts creeping up, that your kidneys may be starting to get into trouble. Nutritional requirements, nutritional support is a huge factor in the success of patients moving along the continuum in burn care. Just some statistics for you. A 40% total body surface area patient left with only oral nutrition, that's them eating on their own free will and accord, will lose up to 25% of their lean body mass in only 3 weeks, so it goes pretty quick. 25% of your weight loss may be seen in burns of greater than 25% in the first month of care. So that would be a devastating weight loss, especially to some smaller people, which is going to deplete your metabolic reserves. Enteral feeding is the preferred route for the major burns. Generally just stick a tube down them and start feeding them. We like to feed our patients very early on, even in the resuscitation phase, and just start trickle feeding them at 10 to 20 cc's per hour. The composition of the feeding should be as follows here, with a protein content of 1.5 to 2 grams per kilogram of body weight, carbs being 60 to 70% of the non-protein calories, fat comprising 30% of the non-protein calories, and making sure that there's an adequate amount of vitamins and micronutrients. How to monitor nutritional support. Daily weights is a huge help, as well as looking at your fluid status as well. Indirect calorimetry if possible. We keep an eye on the albumin. Pre-albumin we do once a week. Also watching the electrolytes as well, and initiating calorie counts, never a bad thing to do, and your dietitians can help you out with that. Early feeding is essential in the burn population, and with early feeding you will have the following benefits. It can prevent a burn ileus from forming, can decrease the incidence of pneumonias, reduce translocation and sepsis in these patients, and as I mentioned prior, feedings may be initiated during the resuscitation phase, but you want to try to reach your goal of tube feeding within the first 3 days of being hospitalized. Burn patients do go into a hypermetabolic state. This hypermetabolic state is being mediated by some internal factors. You've got an increase in cortisol, epinephrine, and glucagon, as well as an increase in the release of catabolic hormones. So what this does is it results in a gluconeogenesis, glycogenolysis, and some muscle proteolysis. And that throws you into a hypermetabolic state, and then you'll start seeing the following things. You're going to start seeing a marked tachycardia, elevated energy expenditure, which is very easy to see if you've got a metabolic heart to be able to hook up to patients, increased O2 consumption, proteolysis, which is going to lead to a pretty impressive nitrogen loss, lipolysis, and you're also going to run into insulin resistance due to the increased release of cortisol, and which is then going to lead you down a road of hyperglycemia. So an estimation of caloric requirements, indirect calorimetry, utilizing the Harris-Benedict equation, as you can see here. Little variations in the difference between men and women. And like I mentioned before, if you have the use of a metabolic monitor to calculate your O2 consumption and your CO2 production, it would be wonderful if you could use that to help calculate your metabolic rate. Nutritional needs of the burn patient. You want to calculate your estimated caloric needs. As I mentioned prior, you want to initiate feeding within the first 4 hours of admission, if at all possible. Considering gastric or distal feeding tubes, distal being the best way you can place a feeding tube. A lot of times it is purely by luck that you can get it down there. But if you can get it down there and confirm it by x-ray, that's fantastic. That's going to lead to more of a constant flow rate of feeding and less chance of it coming back out on you. Enteral feeding products such as Promote and Pivot. You can see the nutritional profile it has been provided for you here as well. And for your patients that are taking PO, make sure that you provide supplements such as Ensure, Glucerna for your diabetic patients. Just make sure that they are provided with supplementation to help keep their caloric needs up. So the labs that we look at generally on a Q6-hour basis for our patients that first come in the door are Chem7, Mag-Phos, albumin, CBC with differential, arterial blood gases, and lactate. As time goes on, your patient has come out of the resuscitation phase, you can then start stretching out to BID labs and then to Q-day labs. We also do look at liver function tests as well as iron studies, ferritin, erythropoietin, retic counts, and if you're going to be having your patient on a low molecular weight heparin therapy, if your patient's going to be with you for a while, looking at the anti-10A levels to make sure that you're maximizing your low molecular heparin therapy. Electrolyte replacement. Potassium, mag, calcium, phos. Generally, just keep an eye on lights. Make sure that the lights are being replaced as needed. Sometimes within the first 24 hours, potassium can be released from injured tissues and red cells, but with the increase of fluids, it can lead to a dilute profile as well. So you just want to make sure that with the insensible loss, with the urinary output, and all the fluids that you're giving, that you're keeping up on the patient's electrolytes. And a lot of times it is chasing your tail, but it is important to keep up with those electrolytes. Chest x-rays, we do them daily on patients that are intubated, obviously, as well as those with trach. And with those who are suspected pneumonia or an inhalation injury, we keep a very good close eye on their chest x-rays. Venous Doppler flow studies are important for the patients that you think are going to be with you for a while, or that even you're going to be transferring out. As well as patients who have central venous catheters or arterial lines in the groin, central venous catheters in the groin, or central venous catheters up above in the neck or in the subclavian route, to keep an eye that DVTs are not forming. Anxiolytics, analgesics, and neuromuscular blockades. Definitely these are classes of drugs that are imperative for burn patients to have access to and to optimize their therapy to get them comfortable so you can do what you need to do to get them up on the road and get their wound care done and to keep them comfortable. So intermittent anxiolytics, the use of lorazepam can be used as 1 to 2 milligrams every 3 to 4 hours as needed. This can be given as an IV or PO route. Generally on your bigger burns, this is going to be definitely more of the IV route. Midazolam or Versed is also an agent that we can utilize as 1 to 2 milligrams every 3 to 4 hours given in the IV route, like Ativan. Continuous strips of Ativan and Versed can also be used, generally starting about 1 to 2 milligrams and titrating up until you get to a point where your patient is comfortable. In analgesics, intermittently you can use oxycodone as a PO agent or morphine as an IV agent. Continuous drips, you can use morphine or fentanyl, whichever. If your patient is obviously having some cardiogenic effects, you may want to use the fentanyl over the morphine. Neuromuscular blockade. Generally, we start with a loading dose of 5 to 10 milligrams, and then putting them on a drip of starting around 5 milligrams, utilizing your train of 4. We try to keep our patients around 2 to 3 out of 4. And just to make sure that we have them blocked enough. And important, obviously, this is something that almost everybody knows, but just to reiterate the importance of making sure that analgesia and sedation are on board, and that your patient is comfortable before they are given the neuromuscular blockade. So one of the miscellaneous issues in critical care, burn, that is the mnemonic of the faster hugs. We look at this BID in our patients, usually in morning rounds and in evening rounds, and it's a good way to make sure that your patients are getting the adequate things that they need on a daily basis. So this is, just to go down the mnemonic, it's feedings and fluids, analgesia, sedation, thromboprophylaxis, keeping the head in an upright position, ulcer prophylaxis, the use of glycemic control, spontaneous breathing trial if your patient is to that point, a good bowel regimen, indwelling catheter removal, and de-escalation of antibiotics if permissible. Comorbidities, these are things that we see in daily patients, but if your patient is not resuscitating the way you want, they're just not behaving the way you want, you don't have a medical history, just things to keep in the back of your mind are renal disease. If your patient's not making urine, who knows, they could have been on dialysis for a while, they could be anuric hitting the door, so it's something to keep in mind. A cardiac history, if the patient has CHF, has had past MIs, has heart failure, also something to keep in mind. Pulmonary disease like COPD, chronic bronchitis, people that are smokers, people that have pre-existing diabetes, people that are drug, tobacco, and alcohol users, and not only users but abusers, which can lead to a sequelae of other problems. And the big one that we're seeing more and more in our society is obesity, which can lead to a whole other host of problems, as we all know. We do use a multidisciplinary approach here at the Burn Center, and we suggest this for everybody that is going to take care of burns, because there are so many complex issues that follow a burn and burn care, not only for the acute care phase, but even down the road after the patients are discharged. So in our multidisciplinary team, we've got a host of people. The surgeons, we have anesthesiologists and critical care intensivists, not only for our adult patients, but we have pediatric specialized folks that can provide this care as well. We have nurses that are certified in caring for burns, respiratory therapists, physical and occupational therapists that are our own. We have our own social workers, our own dietitians, clinical psychologists and psychiatrists, which is imperative to have in this population, especially with all the image disturbance issues that may come up. Clergy is great to have on hand. Financial representatives that can work in concert with case managers to get people the services that they need while they are in the hospital, as well as organizing therapy and placement for people that may need rehab down the road outside of the hospital. We're fortunate enough to have a child life specialist, which you may or may not have at your facility, which if you do end up getting kids, can be a wealth of knowledge and help for you as well.